This lecture will take you through a summary of some of the concepts as it refers to hypertension or high blood pressure, hypotension, and a quick overview of some of the venous disorders as looking at venous blood flow. So starting with hypertension or high blood pressure, it is assumed at this point that you have some basic understanding of what we're talking about when we're measuring blood pressure. If you don't recall that information, the book does give you an overview of understanding the determinants of blood pressure. I encourage you to take a look at that and go through, make sure you're understanding what we're measuring when we look at systolic pressure. It's really getting a measure of the stroke volume, the pressure behind the blood that's being injected from the heart with each heartbeat, and that the diastolic reflects that energy that's contained within the vessel once the aortic valve closes and still is capable of propelling the blood through the arteries in between each heartbeat so that you'll have continuous blood flow. So if you're not familiar with those concepts or what those measurements are, you've forgotten them, please review that. You don't have to go to anywhere else besides right there in the same chapter, and it'll go over some of those factors for you. Talks a little bit about the hormones that are involved in the regulation of blood pressure. This is something you should also already be familiar with. Knowing the RAA pathway comes into effect here. Knowing the neural mechanisms, the sympathetic nervous system, all of that is reviewed for you here in this chapter. Again, that's assumed that you would have an appreciation and understanding of the catecholamines, epinephrine, norepinephrine, dopamine that increase, those are coming from the sympathetic nervous system, and they increase vasoconstriction, vasodilation in the vessels, and can lead to hypertension. So increased catecholamines will increase blood pressure throughout the body. There are the baroreceptors that play a role in that. Those baroreceptors respond to the increases in blood pressure, and they're located in various areas at the carotid sinus, within the aortic arch. They are responding to changes in pressure and send feedback through the autonomic nervous system. So please review that information. It's assumed you understand those mechanisms in order to understand hypertension and eventually how to understand how hypertension leads to other issues with cardiovascular function. So here on this slide we have the classification of blood pressure. I do want you to be familiar with the values here. Normal blood pressure, we're going to go with what the table has here in the book. Below 120 over 80 or over below 80 are ideal. So again, 120 over 80 is normal. Anything a little lower than that is really what we're desired. 120 over 80 is like the uppermost edge of normal. Pre-hypertensive goes then above that, and then there's stage 1 and stage 2. Keeping in mind a single blood pressure reading, it does not diagnose hypertension. There can be a number of issues going on at the particular moment in time, and so it has to be checked over time to be determined if in fact the hypertension is occurring. So if you see somebody who's got a blood pressure of 160 over 110, 170 over 110, you don't wait a year and say, well, come back in a year and we'll see where you're at. But we are going to watch very carefully and check them even within a single doctor's visit. It may be checked a couple of times along the way just to see, keep them there for a little while and see what's going on. Call them back in a week. Look at other aspects of what's going on, but do be aware of what we're dealing with here. So when we talk hypertension, we are talking about consistently increased blood pressure. So not a single time, but consistently increased blood pressure. Now, we can break hypertension down into two main categories. Essential or primary is often idiopathic, meaning there's no known cause. Remember that I've had that term before. Idiopathic is no known cause. Risk factors include things like family history, age related. Just the older you get, the more likely you are to have increased blood pressure or hypertension. Particularly postmenopausal women will see that happening. They've lost the protection of estrogen, and that will go up. We see it is more common in African Americans. This is not just in the United States. This would be a worldwide issue. So it is not, we're listing them as African Americans, but African in general tend to have higher blood pressures. Certainly it's linked to high sodium intake because that increases blood volume, which increases blood pressure. It's linked to obesity, physical inactivity, excessive alcohol intake, oral contraceptive use, and those who suffer from sleep apnea are at greatest risk for hypertension. I don't recall if I mentioned it in the beginning, but certainly family history, there is some linkage to it, even if it can't be specifically linked to particular genes. It does tend to run in families. Note that in essential or primary hypertension, both the systolic and the diastolic values tend to be elevated. Manifestations for essential hypertension are typically asymptomatic for long periods of time. So a person can suffer from sustained hypertension, and if they're not being checked, they may not know it for years until organ damage begins to occur. And recall what we did in previous lectures, it can lead to development of aneurysms, so hypertension is a real problem there, particularly if vessels are already weakened. And so the biggest risk is if we have damage to vessels, aneurysms form, small tears form, leads to clots formation, that kind of thing. That's usually often when you first recognize what's going on. Hypertension is also very damaging to the smaller vessels, the weaker, thinner-walled vessels just in general. So we're talking the arterioles and capillaries. So in areas where we have very small vessels, things like the eyes, the kidneys, the vessels that surround the peritubular capillaries that surround the nephrons are very small vessels. So the kidneys are at great risk for damage from hypertension. Certainly the heart is at risk. Its demands are so great that we cannot have damage to those small capillaries feeding the myocardium or muscle tissue of the heart. And certainly the blood vessels themselves can be because remember, blood vessels themselves have their own circulatory system, the vasa vasorum, that are included in that. So that can be a problem. One of the major risk factors is atherosclerosis. So any manifestation of atherosclerosis is linked to manifestations, therefore, of hypertension. Let me say that again so that's clear. One of the risk factors for hypertension is atherosclerosis. So we went through in previous lecture on manifestations of atherosclerosis in different various vessels throughout the body. So since atherosclerosis is a risk factor for hypertension, therefore all the manifestations, such as for instance in the lower vessels you can have intermittent claudication, that can occur in hypertension if in fact the cause of the hypertension or the risk factor for the hypertension is atherosclerosis. So you can bring in a whole slew of other manifestations that are not solely belonging to hypertension but are also linked to the fact that the patient has atherosclerosis as well. There are particularly damage effects to the left side of the heart. So if we're talking small vessels that are damaged, and it happens to be the vessels in the heart, that increased workload that's necessary to that the left side of the heart does, because the left side, remember, in your blood flow, left side of the heart is pumping the blood out to the entire body. So an increased pressure is necessary for injection of the blood. That makes it harder for the blood to for the heart to get the blood out. So it can be affected by hypertension in particular. Now, secondary hypertension is due to some other disease, and therefore, because it's due to something else, it is more likely something that we can correct or cure. If we take care of the underlying cause, therefore, we'll take care of the hypertension, fix that problem, and then the hypertension will alleviate. In essential or primary, it's idiopathic. We've got some risk factors that are involved, and we seem to see that if you have weight loss and so forth, that the blood pressure may go down. But in many cases, essential hypertension is idiopathic. We can't link it to smoking, anything else in particular, and the only way to deal with it is through medications, because lifestyle changes don't necessarily make a difference. The person may not have been living a bad lifestyle in the first place. But in secondary, we do know what it's caused, and the most common cause of secondary hypertension is renal hypertension, either due to acute or chronic renal failure. And so this occurs when if there's some sort of blockage at a renal artery, that can be a cause of renal hypertension. Excessive renin production. Think your RAA pathway. So the amount of renin goes up, you're going to see renal hypertension, which can lead to body-wide hypertension. And any kind of excessive retention of sodium. So think about your disorders in which you have an excessive retention of sodium. That's in increased levels of aldosterone. So that's linked to Cushing's disease, because that's going to raise blood pressure, increased sodium. So if we can deal with why the adrenal cortex is overproducing initially the cortisol and eventually the aldosterone, we can solve that problem and bring the blood pressure back down, because we'll have less production or less retention of sodium. Other things that cause secondary hypertension is hyperthyroidism, increased metabolism, increased T3, T4 levels can do that. But note, I also have hypothyroidism here. Hypothyroidism causes deposits of carbohydrates inside vessel walls. Recall what's happening in hypothyroidism. You got to think back to the beginning of the course now. You had mucin production, and so that led to the edema, that hard, non-pitting edema, because of the accumulations of the carbohydrates, because the body's metabolism is so slow, things are not being, the nutrients brought in are not being metabolized. Well, those things can start to accumulate in blood vessels, causing blockages. When you have blockages in blood vessels, you'll get higher blood pressure. So both hyperthyroidism with the effects of the increased T3 and T4 it's the same as a sympathetic response, really, and like a catecholamine, which T3 and T4, be careful, they're not catecholamines, but like a catecholamine, they work together with them. It can increase the vasoconstriction and increase blood pressure, or cause hypertension. Hypothyroidism is accumulations in the blood vessels, causes blockages. When you block blood vessels, you cause hypertension. Likewise, hypercalcemia is excessive calcium deposits in the vessel walls. We've been talking about calcemia since the beginning of the course, both intracellular, and here is this is in the extracellular fluid. This is calcium deposits in the blood vessel walls. These are those calcifications that we had back in Chapter 2. Again, increased sympathetic stimulation in the catecholamines. They can increase the vasoconstriction and cause hypertension. Other things like excessive growth hormone is something else. It causes a thickening of vessel walls, and it too can cause hypertension, because if the vessel wall thickens, it loses its elasticity, so it doesn't stretch. That's going to, when the blood flow comes in, it doesn't give way, and that increases resistance and therefore increases blood pressure. Okay. The book goes through a couple of other types of issues with blood pressure. Don't worry about the sections on special populations, like during pregnancy, in the elderly, in children. We're going to skip that for this unit. And the only other type of blood pressure issue I want to mention is what's referred to as isolated systolic increased BP. It's also referred to as coarctation of the aorta. And in this case, what you have is a narrowing of the aorta just distal to the origin of the subclavian arteries. Think about your arch of the aorta. You have the brachiocephalic, the left common carotid, and then the left subclavian branching off from the arch of the aorta. So that's really the area primarily where we're looking at, is where that subclavian comes off. The subclavian on the right side is going to branch off the brachiocephalic trunk. So that the right side as well. Both of them are coming off that arch of the aorta. It's just you've got the brachiocephalic before you have the subclavian when you're going to the right side. So what you have is a hardening and narrowing of the aorta just past the origin, primarily of the left subclavian, although it has been known to occur on the right. The narrowed artery therefore increases the systolic blood pressure. That narrowing of the aorta causes there to be a greater need to push blood past that part. When the ventricle contracts, it is trying to eject the blood up through the arch of the aorta, ascending an arch of the aorta, and out into those first three branches. If there's a narrowing of it there, that increases the pressure in the aorta itself, and therefore the systolic pressure must rise in order to meet that demand to get the blood flow out. So it's a particular problem for the upper part of the body, and therefore with coarctation of the aorta, you'll often find in this situation you have a higher blood pressure from the upper part of the body. So if you take the blood pressure at the brachial artery on the left arm, blood pressure would be high. But if you took blood pressure from the femoral artery on the leg, blood pressure would be more normal. So this is a secondary hypertension. It's more common in younger people. And you can see again, a high blood pressure on a young person on the upper, they'll take it on the arm and then go, wow, that's really high blood pressure for someone so young. Take it somewhere else on the body, the lower limb, and determine that in fact that's a normal BP. That'll be an indication that this condition exists. At that point, you can surgically go in and repair the defect and widen the where that narrowing is in the aorta, and through repair you can solve this problem and blood pressure can return to normal. Alright, so that's hypertension. Hypotension or orthostatic hypotension. Please take a look in your book on page 436 and 437 to read through this information. What we're really looking at here is an abnormal drop in blood pressure when you go from prone state, you're lying or sitting, to a relatively rapid point at which you stand up. Now, the picture that's here in this picture is also here in your book. Please take a look at that because this demonstrates what's actually happening if you are in a prone or a lying position. You'll have, even if you're sitting and you have, ideally even reclining, you have the blood that pools in the lower portion of the body. There's decreased venous return to the heart. And let me just mention here with regards to venous return to the heart, when the blood is in the veins, and we're going to talk about the veins in just a second, when the blood's in the veins, there's very little pressure still left in those vessels. You've pumped the blood out through the left side of the heart, out to the body tissues. If you have normal BP, that initial pressure coming out of the aorta is around 120 millimeters of mercury, but by the time you get to the capillary beds, that pressure's dropped down to about 35-40 millimeters of mercury. As you move through the branches of the arterioles, meta-arterioles, and in through that capillary bed, the pressure will continue to drop. As you branch, the pressure drops. When you get to the venous side, you start converging back together into the small venules and the venules and small veins. That pressure in that vessels is about 10 to 15 millimeters of mercury, and it's still dropping because as you converge together, the vessels get larger and pressure continues to drop further and further. So that really by the time you get back to the right atrium, there's hardly any pressure left propelling that venous blood back into the heart. So you rely on two main mechanisms for blood to return to the heart. You rely on what we call the skeletal muscle pump. It's the ability of your skeletal muscles in your legs get up and move around, and it will push the blood back up. Your veins have valves in them, and that propelling of the blood plus the valves catching any backflow help propel the blood back to the heart. And you also have what's referred to as the respiratory pump. Refers to the changes in pressures primarily in the thoracic cavity, but also in the abdominal cavity as you inhale and exhale, and that diaphragm, which is an arched muscle, flattens. It pushes against the abdominal into the abdominal cavity and propels against the blood vessels and helps pump blood with each breath you pump blood back up through the veins, back up to the heart. So hopefully those two terms, respiratory pump and skeletal muscle pump, are not new terms to you. You learned those in A&P 2. Nonetheless, in our little purple boxes here, this is reminding us that when you're in a prone position, blood pools in the lower portion of the body. There is decreased venous return because you're just sitting there and you're breathing shallow and you're not moving your legs. Therefore, there's also decreased cardiac output because you have more blood in the venous side, less in the arterial side, and so there's only so much blood in your body, and therefore there's less cardiac output, and there's also drops in blood pressure. Then you stand up, and if you stand up quickly, what should happen is immediately the skeletal muscle pumps are activated. This compresses the veins and helps with venous return. And likewise, because of these drops in pressure, your baroreceptors and the carotid sinuses and the arch of the aorta and these vessels, they respond by sending signals to the sympathetic nervous system to increase your heart rate, increase vasoconstriction, increase blood pressure, and bring your blood pressure back towards normal. So as soon as the demand is there and your sympathetic is stimulated, that should be what happens. Now, causes of what we'd call orthostatic or postural hypotension, where this mechanism doesn't work well, where you don't have a return to normal blood pressure very quickly, occurs if you already have an overall reduced blood volume, so somewhere you're losing blood or you're dehydrated. It can be drug-induced. Certain medications can lead to hypotension. This whole mechanism, particularly with the baroreceptors, doesn't work well as you age, and extensive bed rest can actually shut down some of these mechanisms, certainly weaken skeletal muscles in general, so that can be a problem. And there can be autonomic nervous system dysfunction. Neuropathies are damage to nerves. We'll talk about different types of neuropathies that can occur with diabetes mellitus. So in this case, that's going to affect autonomic nervous system function. CVAs are another possible cause of orthostatic hypotension. CVAs refer to cerebral vascular accidents. So we're talking about some kind of stroke that can cause damage to sympathetic receptors in the brain, the stimulation to get that sympathetic system moving again, and certainly spinal cord injuries can also be a problem for postural hypotension, because you obviously, if you have spinal cord injury, you may have very well lost your skeletal muscle pump, cardiac muscle pump as well. So there are obviously can impede your ability to bring your blood pressure back to normal. This can be a particular problem if you don't have other mechanisms in place in order to stimulate those receptors and get things going. So please be sure that you've read through this a little bit, and understand particularly the mechanism, what's going on here, and how we get our blood pressure back to normal. And then finally in this lecture is the disorders of venous circulation. Now, I'm not going to lecture through on this. It's covered in pages 376 through 380. There's basically three things you want to look at: the development of varicose veins. And when we're looking at varicose veins, we're really dealing with some issue with failure of the valves, and therefore the valves don't manage. Remember what I said just previously in terms of blood flow through the skeletal muscle pump? It should catch the backflow of blood and help to propel it forward. In varicose veins, the veins fail to handle that backflow. The flaps of the valves give way. Certainly it's linked to issues of increased blood volume and increased workload on those veins. Primary varicose veins originate in the superficial saphenous veins, and secondary varicose veins usually result in impaired blood flow in the more deep veins. So primary is usually the saphenous. They're more visible. There's more pain often associated with the ones that occur in the deep veins. Again, so read through that, Chronic venous insufficiency refers to problems of deep vein thrombosis. So really chronic venous insufficiency and venous thrombosis are linked to each other. What we're looking at with venous insufficiency is really the inability of the veins to manage to return the blood to the heart. Signs and symptoms are associated with impaired blood flow. Ischemia can cause arterial insufficiency, whereas venous insufficiency is due to tissue congestion, edema, and eventually leading to problems of impaired nutrition at the tissues and at the vessel wall. So read through that to get a sense of what we're dealing with here, factors that can be associated with with venous circulation. And just again, it's not a whole lot to read, so that's why I'm not taking, in fact, I traditionally never take any of the lectures through that. Just ask you to read it and be familiar with the terminology and what we're really dealing with: varicose veins, venous insufficiency, and venous thrombosis. It's the clots that are forming within the veins due to the low blood flow. Blood starts to coagulate and clots tend to form. Okay, that'll take you to the end of this lecture.